on this computer. There we go. Because we're going to post this to the Georgia Medical Director Association YouTube channel. So you just type in Georgia Medical Director Association, and the first one you'll see is Dave Ringer with our first grand rounds. And then we're going to do this one too. I am really excited to help present this with Dr. Miles. She volunteered quickly, and I was thrilled. We have not just a problem, we have a crisis in that so many healthcare providers in the nursing homes are having concerns about the vaccine. And we have got to get this out to them, period. My purpose is to try to get as many medical directors as possible in front of these CNAs and nurses and having in-services and things like that. And quite frankly, I'm pounding on the administrators by mail and otherwise to make sure their doctors get involved. And if they don't, they have a problem because it can be serious if our providers don't get the vaccines. It looks like the patients are pretty well willing to do that. But we'll see. And there's some valid reasons, and that's why Dr. Miles is here. She's an expert in epidemiology and things of this sort, and I wanted her to take most of the hour and talk about these things. But by the end of the hour, and I may do this right now and then follow up on the end, AMDA has created 4 really, really good tools for medical directors or anybody else to use to teach this. So you don't have to go and do your own research and everything. Swati Gar pretty much headed up most of this. And Dr. Gar, is one of ours here in Georgia. So you can go to PALTC, post-acute long-term care.org. That's AMDA's new website. I think if you go to AMDA.org, you get the same thing. And then go to COVID-19 and click on that and then look at the tools for the vaccine. You can download all of these. One of them is a PowerPoint presentation, which is really good. And you can do a PowerPoint or you can print them out, two slides to a page and hand them out, and you can go over it. Another one is a 5-page question and answers and I may go over that a little bit in detail, that you'll know how to answer the questions or even bring the questions up and then answer them yourself in front of a group like that. There's a letter, a form letter on Word for medical directors to send out to families and tell them about the vaccines and why we need them to take them and all that sort of stuff. I'm trying to remember the 4th tool. There's the slides. There's the letter. And the 4th tool is strategies for improving staff and resident confidence. So it's got all sorts of things that you and the administrator can go over and talk about to get those strategies figured out. We're out of time. The vaccine is coming in the next week or so. And CVS and Walgreens, and I think they allow big companies like Pruitt Pharmacy and Elder Care Pharmacy to do it. I don't know who's going to do it in the different homes, but somebody's going to be walking in that door with a pile of vaccines, and they're going to be vaccinating patients and staff. We want to make sure that our providers are there, available to take the vaccine. There's going to be a webinar at 1 o'clock tomorrow afternoon by the Department of Public Health. And they're going to give us their take on the distribution of the vaccines to nursing homes. So I'm definitely going to be on that, and we'll report back. But if you want to get on that, I'll flip the page on a screen share so you'll be able to get the link. But this is coming fast, and we can't fail. That's just all there is to it. So, Dr. Miles, I'm going to turn this over to you. Let's see if I can do this correctly.
So you click on the share screen, and then it says
one participant can share at a time. Can you pick it up now? Nope.
Well, do you have the same screensaver I do on my laptop?
No. Let me see. Stop my share and go to.
I don't really. I could do the.
Okay. we'll
speak through
just
you.
look at you.
Yeah, look at
Okay.
me.
We'll
Because,
flip it. If you need something, we'll flip it.
okay, so one of the things, why am I seeing you and not me?
I don't see me when I talk.
Oh, okay. Anyway,
I can
so
see
I
you.
want to, all right, I want to thank you all for taking time in the middle of the day. I know everybody's crazy busy, hair on fire. My hair was on fire and I put it out. This is a very, kind of at a critical moment, and I don't have to tell you that. And AMDA has provided us with more, we've been kind of overwhelmed with data about the vaccine, about the trials. My husband basically said he was tired of seeing people get jabbed in the arm on television. I mean, the information, the facts, as we know them, the science is out there. And so what I would like to do today is engage you all in some feedback around how you make the decision for yourself, because that's the first group. We all have to make a decision for ourselves. Hopefully that decision is we're going to protect everybody around us. And then the question is, how do you convey your decision-making process to the other folks who work in your space? Because I think, at least in the environments that I am involved in, people want to know how I feel about it and what I'm going to do. So one of the things I'm going to show you, if you look at the bottom of your screen, you'll see a little button, a smiley face that has reactions. So, you know, so I want you all to click on the heart so I'll know that you can do this. Those hearts. And those of you who are on the phone can't do that, but I'm seeing hearts pop up. That's good. That's good. Thumbs up. Because it really is, one of the things, and Dr. Warnock has heard this before. When I teach at the University of Georgia, and I teach public health students, many of whom are adults with families and jobs, and they make a decision to come evenings or weekends and study epidemiology to get where they want to go. And so one of the things they all have to learn at the beginning of that class is how to make a decision with less than fulsome information. So there are many things about the world, even though you know all the epidemiology methods and you know how to calculate things, there's still gaps in your knowledge. And as someone who practices medicine, you take all that you know and you bring it to that moment in time where you're treating somebody, and then you make a decision and you move forward. And only time will tell if you've made a good decision, I won't say right, but a good decision, or one that was not so good, and then you fix the problems. That is the way it works for us. One of the things I call that decision-making process a WAG. You basically take all that you know, and if I could see all your faces, I would know how much knowledge we have in front of us. By the way, how many of you are nurses? Give me a heart. All you nurses, give me some heart. I can see who's there. Okay. All right. Okay. And how many are physicians? Heartless physicians. You can use whatever face you want. Okay, we got 2. So, okay, Painter. Do you know how to use the chat? If you know how to use the chat function, Laura, put in the chat box your sort of area of expertise. I know we have some pharmacy people here. So we all come at the world. The point I'm trying to make here, and will help me talk to you about this, is we all come to the same situation, but we bring a different skill set. That's also something we do a lot of in public health. And so the WAGs that we make are not just guessing. That's what the G stands for. I do say wild because we are accumulating all that knowledge and making a determination. The WAG is our way of harnessing all that information, feeling comfortable with the decision, and moving forward. And that's really, as I process, how I'm thinking about this vaccine for myself. Because, you know, I'm old enough to be in the group that they want to vaccinate. You know, that's how I'm processing it. I saw Neil Pruitt on television last night. How many of you watch 11 Alive News? Or get to see it? No? None? Neil Pruitt said on television and on camera that he would get the vaccine. And I think that's what it's going to take. All right, nursing and pharmacy. Yes, it's going to take all of us modeling the right behavior, seriously, to engage everyone. I think our patients, my students especially, have been watching me all semester. How do I behave? I'm at home where I have a mask on, and I know some of you are probably in areas where you need to be masked up, and that's good. I can pull my mask out at the end when Perry starts talking so you can see it. We are often the most educated person in a room full of people who are waiting to hear what we say about things. And so our language matters. And if I feel like I'm your mother telling you what to do, yeah, I kind of feel maternal about this. But that's really what it's going to take. We are one of the things I want you to think about as you're trying to figure out what to do and how to guide people into making a decision that you think is the right one. I've worked really hard not to be coercive in my modeling of behavior because I think telling people what they ought to do, you know, shaking your finger in their face is not going to work. George, I lived in Texas for a long time. Telling Texans what to do is like herding cats. Not happening. Not happening. And you can laugh if you want to. Those of you who know me know that I don't mind having humor with really hard conversations. So, you know, I know you're all muted, but unmute if you start laughing because I need to hear that too. So what I would like to share with you is my own experience. There we go. Perry's like, give me a face. My own experience with thinking through big disease outbreaks and how that influences how I made a decision about the vaccine. My own decision making about influenza, which for years and years and years I didn't get, but now I do on a regular basis. And it's not about age. And other aspects of healthcare, because I'm certain that a number of you haven't guessed, I am African American, I have been all my life. And the trust in the healthcare system, even for someone with all my training and all my experience, sometimes I'm not. Okay? So I'm going to be completely honest because we're, you know, Perry, you might not want to tape all of this.
Too late.
Too late on
Total honesty.
Yeah, no, I think because we have to be honest with each other, with ourselves, and with the people that we care and lead. So, so I lived through as a resident the era when AIDS was not HIV, but it was full-blown AIDS. And I worked in a big hospital where we saw 30-year-old guys die every single day for months. And I know that many of you have lived through the recent experience in Georgia with COVID in long-term care. and that you've seen, residents, and that you've had uh, uh, colleagues, um, or you've had staff die. That is that experience never leaves you. I can tell you from personal experience, it takes a long time to process that. And if you are, there are many ways you can process that, make meaning out of that. You can harden your heart and say, I'm not touched by any of that. Or you can say, you know, I'll never let that happen again. There's just many ways we process that as healthcare providers, because we still want to go on caring for people. So I'm assuming that all of that is in place. Am I wrong about that? Can somebody like fart in my direction? All right, Barry's giving me a thumbs up. Anybody else? All right, Dr. Adler, Warnock. Yes, so that is sort of the floor of how you're going to make that decision and how you're going to talk to other people about it. Because you got a lot of folks who are really dedicated. I've spent a lot of my time, those of you who don't know me, I have a bereavement care project that goes statewide, and any day now you'll be getting a toolkit from us. So I've spent a lot of time, hours and hours, talking to residents and staff, and not medical staff, environmental staff, dietary, everyone who works in that environment about their experience with loss and how they cope with it. And I think COVID has just put a sharp point on what folks who work and live in that environment know anyway. And so part of that, I use part of that to inform my making a decision about this vaccine. And I'm assuming that for this conversation, we're going to put all that crap that you're hearing in the larger society, politics and all the newsmakers, because they're not involved in where we live. So having lived through the AIDS epidemic, that's how I became interested in bereavement care. I could see that a lot of people were injured by the passing of someone else. There were staff members who were injured by the process surrounding that person's dying. There were families that were torn apart by that. And so anything we can do to lower the temperature on that, I think, is really important. And that's part of what informed my decision to get this vaccine. So anybody wanna, it's very difficult for me to just sit here and go blah, 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 blah. It helps if someone else can share their experiences at once.
Everybody, you have the ability to unmute and talk and show yourself or whatever. This is a conversation. That's what Grand Rounds is all about. So when the speaker says chime in, somebody chime in.
Tony, I'll chime in. Concern I have, and concern I hear from a lot of people, of course, I am not an anti-vaxxer. I believe in the vaccines. I think they've made a huge impact in healthcare through the years. You can look through the 30 years I've practiced and the 100 years we've been doing things, vaccines, what a great impact it has. However, with every vaccine, especially new vaccines, there's issues that were not known before it happened. The old, you test 30,000 people and you get 2% side effect. Well, 2% bad side effect on 30,000 people isn't that many. 2% side effect on 340 million people is quite a few people.
Not to mention it's 100% if it's you.
Absolutely. So I think there's a lot of people that are concerned, not only that this is a new vaccine, there are no animal studies on this vaccine. And I guess, our favorite form of information now is the quote fake news or Facebook or all the other things, which nobody can trust anything. And now they're saying there's going to be sterilization of the entire population in the next 15 years. There's going to be neural tube defects. And then you throw in, we all have just enough knowledge, genetic knowledge. When somebody says mRNA and it's going to affect our DNA, I think people get a little concerned because this is a new mode. Of course, now I'm going to say something horrible, which is for the nursing homes and for the people over 65, 70, 80 years old, who cares? They're not going to live 20 years to see if they have neural tube defects anyway. And if it keeps them from dying in the next year or two, that's great. But I think some of your problem is some of our MAs and staff workers are in their 20s and 30s. Of course, I can hear them say that if I get it, I probably won't die. I might not even get a runny nose. But what we're worried about is them transmitting it to the older folks. So we want them to have the flu shot. But boy, that's hard to make people understand that you're taking this really for other people and you could have a side effect, but we don't think so because our studies on 30,000 people look pretty safe, but we're not sure. Here you go. Go ahead and take it. I mean, I see where people are concerned. And then last, and I know Dr. Warnock and I have talked about this, and you just let me know how old you are because I was a resident during the first AIDS patient, and we didn't know what the heck it was. And of course, I'm gonna. The bad thing was that residents aren't allowed to see COVID patients right now, but we were the only ones that were thrown in with the AIDS patients.
Right.
So times have changed, but Guillain-Barré, was an unknown syndrome until the swine flu and Jimmy Carter threw everybody had to have the swine flu vaccine. And then we as residents were taking care of patients with with Guillain-Barré syndrome, not knowing what it is. So there are some downsides, and I don't know how to defend that to some of these young people that are questioning it, because I don't have the knowledge to say, no, that's not going to happen. We've done plenty of mRNA protein vaccines, and they work perfectly and they never cause problems. No, we haven't done any, and we don't know. So it is challenging to give people good information.
So Dave, you've come out with a million everything.
I know. Sorry, you know me. I won't talk again now.
No, that's okay. So let's take that one by one. So one of the things, and I'll just kind of reflect. So first and foremost, I cannot defend the vaccine in the way people are defending it. I can't defend the science because I don't know as much about the science as I'd like to, okay? My daughter has a degree in microbiology, so I called her up, I said, what is an mRNA vaccine? I don't, that's new. But what I can, I don't even try that route because then it makes me seem like an apologist and I'm trying to be coercive. I want all of us to understand that we make decisions all the time without full information. Medical people especially put themselves at risk. I don't know about you, but I went from being skin test negative to skin test positive for TB sometime during my junior or senior year. And here I am. And the objective answers are there. The question is, are people gonna be able to make that determination? We don't leave these kinds of decisions with our head. Afterwards, the intellect part of your brain says, yeah, this was good. It's like making investments with your money. You're not as objective with your money as you think you are. Same sort of thing. So medical people, and I really am going to show my age, were sort of taught from the beginning that you expose yourself to the risk. It comes with the territory of caring. you take your precautions. That's why you wear gloves when you need to. I mean, the last baby, I'm internal medicine, right? The last baby I delivered was as a resident in the lobby of the hospital because she didn't get up to the floor. And this was during HIV and I didn't have any gloves. And there she was. I had delivered babies as an intern, as a medical student. I went to Howard. So I got down there and delivered that baby barehanded. And later on had to check to make sure she didn't have syphilis and all this other stuff. That is kind of what we do. And there is nothing I'm going to tell people that's going to make them feel 100% certain and safe. Not going to happen. So that's why I attempt to model what I consider good professional behavior. So with my students, we toyed around with the idea of gathering together outside on the porch of the building that I have my office in. And as the community positivity rates here in Athens started to rise, we canceled that because we knew it wasn't good professional behavior to be mask off outside and doing that stuff. So, you can ask them all those questions, or they can ask you all those questions, but eventually it's going to come down to, and it's whether or not you believe the vaccine is going to protect you. I know our young adults have gotten the misunderstanding that they cannot get sick, and many of them will have mild symptoms. But about a third of young adults have some kind of chronic disease. They have asthma. Many of them have pre-diabetes. We're getting people to adulthood who have these problems. And so it is really that group within your CNAs who should consider getting the vaccine for themselves. One of the, let's see, what else did I want? So we hit the unknowns, personal risk. This is the message I want to get across today. It's about assessing your own personal risk and your work in the profession. Did I hit? I know I didn't hit all your points today. Can you bring up something that I missed?
One thing that we might discuss right now, Cheryl Welch just brought it up about, you were talking about coercion and all that stuff. And some of the staff may be concerned about employment at will state. What happens? I think the question is still out there. Can we require the vaccine? A Supreme Court case almost 100 years ago in smallpox against a man in Massachusetts, the Supreme Court ruled that yes, the government can require smallpox vaccinations on anybody. But, obviously we don't want to do that. We want to make people do it on their own. But the one big question is going to be is from the nursing center standpoint, can I require it to protect everybody? From the employee standpoint, what if I'm right up against the wall? Am I going to lose my job if I don't have that? We've already gotten to the point that if you refuse the flu vaccine, you must wear a mask during the entire flu season. So, we need to address that, or the medical directors need to be able to address that.
Yeah. So that brings me to my flu vaccine story. I was not a big, I had flu once in junior high. It was terrible, but I had never had flu since then. And I was not a big proponent of getting the flu vaccine because, for all the reasons I said before. But the other thing is I always went to my major group conferences in the fall at the beginning of flu season. The Gerontological Society of America. So my joke was that I'd go there and hug people and get my immunizations that way. That's dumb. Okay, I will admit I was stupid. Not a way to do that. Because I also had colleagues at that meeting who were themselves frail and did not need to get flu to get exposed that way. And so the year after I started getting them, there were major flu outbreaks, really bad years of flu, and I'm glad that I started doing that. So it really is a personal, it's got to be a personal decision. I don't know, to your question about the workplace, I think it is very reasonable, and I've heard it from some other people, and I would love to hear either in the chat box or someone who's willing to talk about it. The requirement that people who do not get immunized, they have to wear masks all the time, all year. I just happen to think that it's within the long-term care setting, it's the staff have to be immunized because we're the ones who move in and out of the space. Our patients would not be exposed if they weren't exposed to people moving back and forth. And I'm not blaming people for that. That's just the way the life works. So I'd love to hear somebody who hasn't, see, ordinarily, if you were my class, I would call on you by name. I'd call you out. So, but I don't know most of you well enough to do that. And we're friends here. It's okay.
So I'll chime in. This is Swati.
Yes, please.
So on that mandate, is there going to be a mandate? And this is something that is, not a part of vaccine education or anything. It's just a part of me observing as a long-term care physician in a health system kind of context. The number of vaccines that are going to be made available are not going to be enough to vaccinate all healthcare workers, even right now, including the hospital workers, including the home care workers, and the long-term care workers. I think one of the danger that I am seeing here is if we have low rates of vaccination, not everyone is like that. So there is a lot of interest in the hospital systems of people who are like, we will line up. And trust me, those are primarily physicians who want to be vaccinated. So there is a competition, the finite amount of vaccination, vaccines available in this first go round. So I would really, this is where we are as a health system. We are having to prioritize. If my nursing home shows a 30% interest in getting vaccines, then those vaccines are going to be diverted to healthcare providers other places. So I think we need to be very cognizant of that fact. The other thing is, it's not mandated, but in order for it to be effective and for us to ever get to a point where we are not wearing masks, enough of us will have to get vaccinated. And I think that is probably a better conversation with the frontline staff. There is no coercion, but if we are not going to all move forward and get that 70 to 80% vaccination rates in the staff and community and residents, then we are not looking at a world without masks.
Absolutely true.
Yes.
Now, I understand that CVS and Walgreens will come into the nursing home, and again, depending on vaccine availability, they'll come in and vaccinate anybody in that nursing home. And then obviously they got to come back in 3 weeks, 21 days, 28 days, and do it again. So they'll have a record of who got the first one, and the priority will be to make sure they get the second one. And then at that point, they will be able to offer the vaccine again. I don't know. That's something the Georgia Department of Public Health is going to tell us tomorrow at 1 o'clock.
Okay. Yeah, but I really would, and everything, I agree with everything Swati said. It's really important that people know that the workforce knows if they don't express an interest and enthusiasm, they're going to divert it somewhere else, because you can't just open this up and leave it sit in the fridge. This is not that kind of thing. Rick, did you want to say something? No?
I think his mic's open and he coughed.
This is Ralph. I think one of the things that's going to drive acceptance in our facilities is family members They want to get back in to see their loved ones,
Good
period.
point.
And when we tell them, you show us that card at the door, welcome. They're going to do it. And they're going to be in there, and then they're going to want to know why the CNAs didn't get it in order to protect their loved ones even more. I think that's something that we've got to consider, that that's going to be beneficial, but when's it going to occur? I think we're looking at 6 to 7 months and we're going to have a whole group of people who will get vaccinated, and that's going to encourage others when we hopefully do not have a large number of problems like Guillain-Barré and so forth. Just to date myself a little bit, Tony and Dave, Rick understands this. I remember when acquired immunodeficiency syndrome was first described, we didn't know where it came from. Anybody who got sick, we thought they had it. And it was 5 or 6 years. I was already in practice. It was 5 or 6 years before we realized that this was a viral problem transmitted sexually, particularly in the gay community. We started beginning to, and like you said, Tony, started watching people die on a regular basis. I'm tired of watching our patients expire. I've had friends. We had a nurse at the local facility who expired 2 days ago on a ventilator at the hospital because she got COVID. I'm tired of it. And that's one of the things I'm going to tell people. Yes, I'm going to get it, and I'm going to proudly get it, and I'll get some aches and so forth, but a little Tylenol will help that. So I think we got to be patient, because there are a lot of folks who just are not going to do it quickly, even with good education. And these AMDA tools are wonderful because that gives us a lot to go on. But experience is going to be the best educator. And then availability, like you said, this first round is not going to last. Like Swati said, we don't even know what we're going to get yet in our facilities. I know our hospital has got an allocation coming for healthcare workers, and we actually got a grant to be able to purchase one of these deep freezer things. And so we'll be able to store the vaccine here and administer it to our personnel. And our personnel, as somebody said earlier, are already lining up. They're signed up and ready to go. As soon as it shows up, we'll start vaccinating. So there's a lot of enthusiasm, but there's also a lot of skepticism. And I think patience is going to be our best bet, even for Dr. Ring.
I've got a question that maybe Swati can answer. I'm not sure if anybody knows this, but it just came up to me. One of the concerns I've had all along is, yes, the side effect profile is so varied right now. It doesn't seem like a lot, but some, you've heard stories. But is the second shot 28 days later the same viral load, the same shot, you're just boosting it? And do they get just as many side effects the second time, or are you less likely to get side effects the second shot? Because one of my concerns is you're going to have people that jump on board and say, I'm going to take that first shot. They're going to get a temp of 103 the next night, hurt, feel bad, nausea, and say, I ain't getting the second shot. Do we know if the second shot will cause those same side effects, or are they less because when you've already got some immunity, you're building that second immunity up? I don't know if anybody knows that or not, but that would be interesting to be able to tell patients, you might get some side effects the first time, but please come back, because I guess it don't work if you don't get the second one. Does anybody know that?
I don't know the answer to that. Swati, do you have a?
Sure, I can chime in. It's actually, I think, the most important thing that we need to tell people that it is an mRNA vaccine. What that means is it is a synthetic mRNA. It's no part of virus that is in there. It's not a dead virus. It's not a live virus. So all it's doing is, and it doesn't touch your nucleus. I mean, if you remember our biology lesson, right? the nucleus typically produces mRNA, which then goes to the ribosome, and that creates a protein. So when we are already having a synthetic mRNA, it basically is not even touching your nucleus. So there's no way to change your genetic material. That is, one issue that we get commonly. The second is that, once they make a protein that looks like a spike protein, which is on, if you have seen the coronavirus, it's that pretty protein that is like antenna. That's what it looks like. It is not the protein, it can never make the virus. So now it's creating antibodies. Anytime the body goes through the surge of creating antibodies, you are going to have those body aches. You're going to have backache, body ache, myalgias. You can have fever up to 102. You take Tylenol, it's gonna last you 2 days. It's like shingles shot, if anybody has taken a shingles shot. So you're gonna have those. The second time, actually, you're going to have a little bit more severe, because now the antibodies know what a spike protein looks like. It's the same synthetic mRNA that goes into your body, and it creates some more of the spike protein. Now it's a challenge to that antibody. And because your body has already created the antibody, it's ready to fight. And when it's ready to fight, you're going to feel that fight. And it's going to be, you are going to feel those effects with the second vaccine. Actually, you may feel a little bit more than the first time. You may, not every time, but you may.
Yeah, Becca Casey, who's a chicken and is only writing in the chat box, which is fine, says that there's higher reactogenicity with the second dose. So that's, and everything that Swati says is on target.
I think what we got to get across, Tony, is that when you have that reaction, it is working.
Yeah.
It's doing what it's supposed to do.
Absolutely.
Like
Yeah,
Swati said,
absolutely.
it's working.
It's working. And that is it's okay to take something for the pain. I mean, if those of you who've had babies know that when you get those immunizations, baby gets fussy the second time around. And you give them a little Tylenol and you cuddle them. You can find somebody to cuddle you if you're not in a bubble, or if you're in a bubble, and you'll be okay. And the shingles shot, again, one of those, if you've ever seen someone with the shingles, and I saw my dad have that, it's terrible. It's terrible. And so it's everything in life is a balance, the little discomfort with the immunization or demise. That's always the decision we're going to have to make. And so what I work on with my students is they're adults. So we cannot give them 100% metaphysical certitude that life is going to go the way you want it. I tell them that security is a ruse that we make for our children so they can grow up feeling comfortable and happy. We know how uncertain things are. So anybody else want to weigh in? Comments?
I think that's
we're at the quarter of. Go ahead.
I was going to say, I think that's a key issue, right? Like, I've had some of those conversations that Dave Ringer has had. How do I know about GMDA? How do I know about this? Clearly Bill Gates, wants to track me with, as if, my life was interesting enough for Bill Gates, right? But I think your point of, no, it's not a sure thing. Yes, there is risk involved, but there's also risk with not getting the vaccine. And we have a pretty good sense that you don't get the vaccine, you will get infected. And if you get infected, there's a pretty good chance you get sick either initially, or your immune response, or you're a long hauler. And, do you want to roll the dice on that?
Yeah, no, that's perfect. I mean, I have not seen my parents since March. Although my daddy gets us on the phone every Sunday and prays over us. He's really happy that he can do this because we never would agree to this before. But still, it would be wonderful to sit in their kitchen with them. So that's why you get those vaccines. That's why you do it. It is, and as health, Ralph is giving me a heart, thank you. So I didn't want to spend a lot of time with the technical stuff because we're swimming in a sea of technical stuff. And it does come down to the sources that you tap, how you feel about them. And I'm a scientist, okay? Don't get me wrong. I'm not some kind of squishy social. My PhD is in anatomy, all right? I get the whole cells and all of that reactivity stuff. But I know when you're making personal decisions, it's you, it's personal. You got one ship that you fly around the universe in, and you want to keep that ship intact. So teach your staff about a WAG. I didn't tell you what the A stands for. Ralph knows. Ralph, you want to tell him?
No, you go ahead, dear.
Okay, it's scientific wild ass guessing, which is a little more detailed than straight wild ass guessing.
Exactly. So you're going to give them some swag. And letting people talk out their fears. Because it does, those of us who have seen large scale death among our patients will never want to see that again. And whatever you can do to stop that process is what you're going to do, is what it boils down to for me.
Dr. Miles.
Yes, sir.
Hey, it's Dr. George Smith over in Covington. I had a couple of questions for you. I had COVID back in August. It was horrible. I was down for 3 weeks out of the office. I took vitamin C, D3, and zinc, hydroxychloroquine, and azithromycin. And at about 5 days out, I was feeling so well that I stopped the hydroxychloroquine and tanked overnight. And I just got back on it. And over the next 4 or 5 days, I got to feeling better. But of course, the Z-Pack, the azithromycin, ran out at about day 10. And I started coughing again. So I took another Z-Pack, and I finally got over it and got back into my office. Since then, I've treated more than 100 patients as an outpatient in my office with hydroxychloroquine, azithromycin, vitamin C, D3, and zinc. I've had to send several over to the hospital basically because they, a lot of them don't come in within 2 or 3 days. They come in like 7 to 10 days out, and they get, I've seen a lot of people start getting into trouble with pneumonia at that point. But my point being is that of all the people that I've seen, about a half a dozen of them have had to be admitted to the hospital, but no one has been put on a ventilator that I've treated this way, and no one has died. Versus my patient population in the nursing home that's been completely different. Of course, the demented people just can't tell you they're getting into trouble. They can't tell you those symptoms they're having. They stay under the radar of the staff. And so over at Social Circle, we've lost 2 to 4, I think, in a 65-bed facility. At Riverside, nursing home in Covington, we have a 150-bed and 160-bed facility there. And over the course of the past few months, the patient population has gone down into the high 90s or low hundreds, but they've lost more than 30 people at the Riverside nursing home here in town. They're not using hydroxychloroquine or azithromycin or vitamins. So my question being to you is that, hopefully you can answer it. I don't know if you're practicing or you're teaching, but of course, hopefully all of us are teaching. But my question to you is that if people have had the COVID, how long are they going to be immune? And I haven't been able to figure that one out yet. I've seen 45 days, I've seen 90 days, I've seen a year, and that's boggling my mind. And how can somebody say you have immunity for a year when we haven't even known about this for a year? Well, but the other thing is, how long are people going to be immune when they take the COVID vaccine?
Well, the thing I read, I was actually looking for that answer this morning, and anybody else who's seen anything else chime in, but I don't think they know the answer to that question.
No, they don't. And the University of Georgia is heading up that 1-year immunity study. But the recommendation now is if you've had the COVID disease, then go ahead and get the vaccine. Go ahead and get the second dose. You're still building immunity, even another way. So yeah, you just playing all your cards.
Yeah, because the thing about coronavirus, as you probably know, it's the virus that causes the common cold.
Right.
So, no one knows, no one has good data, I'll put it that way, yet to answer your question about how long you're immune after you have a natural infection versus the vaccine. But we're at a point in our national experience of the outbreak that we need to put brakes on things. I mean, we doubled the number of positive cases in a period. We were having one rate one day in November, and we have now doubled that rate. So our doubling rate for infections is ratcheting up. I don't want to get too deep into the epidemiology, but what we're doing with this vaccine is putting the brakes on the transmission, the rate of infection, the spreading it around. And we really need to be able to do that, because the people who are the ones that you've seen who are going to be sick enough to need hospitalization and to die, that is an influence.
Yep.
What?
Rick Weary somewhere in there. Okay,
So-
Tony, we're going about 2:53 right now. I'm going to need to take this thing over and show
Yeah, go
some
ahead
of this
and,
stuff.
So hopefully my cheerleading, which is what I felt like.
Oh yeah.
Thank you. You too.
Go ahead.
I'm sorry.
You too. Have a nice day.
So, somebody's got their mic on and they're talking on the phone or whoever.
That was me, but I'm trying to find out if I'm muted or not.
You're
You're
not.
Rick. Okay. Then I know if I push it again, I'll be muted. Goodbye.
Yeah, you're cool. Thanks, Rick.
So go ahead, Perry.
Okay, let's see
Rick-
if I can.
Rick's the same age. Rick's the same age I am. Y'all forgive him for that.
Okay.
Okay. Once.
Okay, can y'all see that screen? COVID-19 questions.
Yes.
Okay, this is the AMDA PowerPoint. And I just, kind of wanted to go through it quickly to show you. You have access to download that or whatever. And it's a good presentation. Come on. Staff concerns, being a guinea pig, rush,
You want me
that
to,
sort of thing.
If you let me run it, I'll run it for you.
I got it. I got it right here because
Okay.
we're kind of running out of time.
Okay.
Talking about the staff concerns. Why should I get vaccinated to protect the residents? That sort of stuff. Common questions, and I'll show you where you can find the answers, so you'll be really up on that. mRNA vaccines, they do not contain the virus. What's the technology? Well, it's been used in cancer treatments for years and years. And as a cancer patient, I know all about that, so I'm okay with that. Here's your Pfizer test, 40,000, Moderna, 25,000, what the breakdown is by race and ethnicity and age. What is the efficacy? Cannot give you the virus. 1 in 10 will have short-term effects. It's a good thing to have side effects. Things we've been talking about today. You must get the second dose, get the same vaccine. You can't switch them out. Are they safe? They talk about the FDA safety standards, and they've been exceeded by about 2 weeks in those tests. How many people are there? No steps are skipped. The advisory committees are there. So the entire system is just like any old flu vaccine. It's just we took out all the bureaucracy stalls and delays and coffee breaks, and we did it fast.
Perry, can I say one thing about this virus? I know you guys are hearing the phrase Operation Warp Speed for the vaccine.
Yeah.
This vaccine has been in development for 17 years.
Yeah.
It's not new the way the media has portrayed it.
SARS. Exactly right. What is emergency use? Does that mean anybody skipping steps? Why so quickly? Will I still need to wear a mask? Special circumstance, what I've already had it. Where do I get accurate information? Everyone has to do their part in questions. So that's the PowerPoint. I think it's really kind of cool that we can use that. I don't know. I thought I had all four of them brought up. Let's see if I got the one. Screen sharing is stopped. Here we go.
Barry, I'm just going to put a shameless plug while you are looking for that other PowerPoint. This is
Okay.
something that yours truly actually worked on over the past weekend. And this was important because you can actually show it to your nursing home frontline staff. And we made sure that we were clear in language. We were very cognizant of the language, of not putting too complex or too ambiguous words in it. And I hope that it is, and it's really made for so that you can pluck it out and go to your facilities and show it to your staff, because it's important. And my last thing I would say is the physicians are lining up in the whole health system ahead of anybody else. So you got to ask yourself, you know, what they know. Yet we get our CNAs, you know, every time I turn around, this CNA has passed, that CNA has passed. So we just need to close that education gap and make sure that we're talking with our staff and making it really, really easy for them to understand so that they are able to take advantage of the knowledge that is out there.
Absolutely. Here we go. I actually got it.
Marty, where are you putting those slides?
I'm just putting them on my screen. I'm going to show you where to get
it
them.
is on AMDA website.
Absolutely.
And
Okay.
there is a frequently asked questions, and
Yeah,
Perry is telling you all that there is.
Okay. Are you seeing this?
Yes.
Yes.
Okay, good. This is the Q&A sheet. This is about a 5-page document. If you know these 15, 19 questions, and just basic answers to it, this is the questions you're going to get. So you can take this and you can give it out, or if you're talking to RNs and LPNs, you can just answer questions, and it's the same thing that slide presentation went through. And it is a really good handy dandy sheet that you can carry around. So I would definitely get this. You see the same thing: emergency use. How will we be protected? Should we expect the recommendations to change as they're approved? I think there's 6 vaccines out there. All that sort of stuff. So I'm going to stop the share. Anyway, to let you know, go to PALTC. You don't have to be a member. You click on the box that says COVID-19 AIDS, and then it'll flip over and you'll see where it talks about the vaccine to COVID-19. And you can download these things and use them at will. If you're having trouble, drop me a note or call me and I'll send it to you directly on an email. But this is the purpose of today's meeting: give you the tools, give you the thought processes behind that. I really appreciate what Toni said at the beginning of that, in that this is how we as healthcare professionals, and you especially as physicians, come to decision making, and this is really no different. So once you have that excuse me, in your mind, then you can confidently talk about it without coercing, with being able just to give the facts. And you just have no idea the status that you have in a nursing home. They're going to tune out an administrator. They're going to tune out a DON. They have in services all day long. But if a doctor takes the chance or the time to go in and say, hey guys, I really need to talk to you, they're going to sit up straight and listen to this. And that's the key to our survival here. So this was what was so important to me, to get this thing on, to get it recorded. I've volunteered, me and Toni doesn't know this. I told Pam Clayton that Toni and I would give this presentation 5 times on their platform, if necessary, to get to all the nursing homes. We are really trying to make this happen. So thank you so much for being on the grand rounds today. It's 101. So I've got to cut everybody off. I think we had 45 or so participants. Frank Powell just said his internet died. He didn't really get mad and quit. So we're doing okay. And thank you so much for spending your valuable time with us. If you go, let's see, let me get to Pam Clayton's thing. The health department webinar is tomorrow at 1 o'clock. And I hate this second computer. It's finally popping itself up. If you want to get on that webinar, let me know and I'll pop you this letter that has the link on it too. But I definitely will be on it. If anything weird happens, I'll be getting a blast out to all 775 people on my list. So we'll go from there. Thank you very much. We're going to end it today. Dr. Miles, thank you so much. And we'll be back at you. Just a quick little plug at next Tuesday at noon, we're going to have a journal club research rounds, and I'm going to bring a speaker that you will not believe. Zwelathini is his first name, and I just blanked on his last name, but he is a data miner, and you would not believe the data that he knows about medical directors in the state of Georgia. And the way he presents it. And the danger is CMS is going to get a hold of this and they're going to start quality measures for medical directors. So you might want to be on this thing and really see what's going on there. So that's next Tuesday. Thank you very much, and we'll end the call. Appreciate it.
Thanks, Barry.
Thanks, everyone.
Yeah. Thanks for your ears. Thanks, Dave, for
there it goes.
putting me through the ringer.
I know it. The ringer always does that. Talk to y'all.